Hi everyone, welcome back to Next Level Ophthalmology. Today we will be continuing the Sclera chapter and we'll be dealing with episcleritis, scleritis, infectious scleritis, staphyloma and scleral trauma. So let's begin with episcleritis and scleritis. So we know that both of these conditions can cause red eye. So we should know how to differentiate episcleritis, scleritis and a more common and more benign condition known as conjunctivitis. So coming to symptoms, conjunctivitis, we can have minimum foreign body sensation, watering and discharge, whereas episcleritis you can have mild foreign body sensation. Many a time they may be asymptomatic, whereas scleritis is on the other end of the spectrum. There is severe boring ocular pain and may be associated with diminution of vision and painful eye movements. The pain is quite severe and it's usually worse in the early morning. What about associated systemic diseases? Conjunctivitis, we rarely have anything like that, whereas 25% of episcleritis patients and more than 50% of patients with scleritis can have associated autoimmune conditions. The type of congestion in conjunctivitis, it's usually just diffuse superficial congestion. The vessels are branching in nature. Okay. In episcleritis, the redness is usually localized when it is a nodular episcleritis and these vessels appear radiating. Okay. In scleritis, the congestion is more dark and purplish. It's deeper and it appears crisscross because of the arrangement of blood vessels. So what happens when you instill 1% phenylephrine? The congestion decreases in both conjunctivitis and episcleritis because these are superficial vascular dilatation, whereas in deep vessels as in scleritis there is no effect on the congestion. Ocular associations, conjunctivitis can rarely cause peripheral keratitis. Episcleritis has none, whereas scleritis may be associated with uveitis, cataract formation and sclerokeratitis. So let's classify them. Episcleritis is a simple classification. It can be diffuse or nodular, whereas scleritis we follow the Watson and Hyre classification, which is time tested and it holds good even today. So scleritis can be classified as anterior and posterior. Anterior we have non-necrotizing and necrotizing. In non-necrotizing we have diffuse and nodular. In necrotizing we have with inflammation and without inflammation. Another way of classifying scleritis is based on whether it is caused by an infectious etiology or an autoimmune condition. So what are the systemic associations? In episcleritis we have a lot of systemic associations, but remember most of the time it can be idiopathic and you have some ocular associations as well. Like many a time it can be associated with severe blepharitis. Okay, it can also be seen in association with helminthiasis. So it can also be seen in association with pulmonary tuberculosis. So these are the conditions that are more commonly seen. Then rheumatoid arthritis is the most common systemic collagen vascular disease that is associated with episcleritis. So these are all rare conditions that can have episcleritis as a presenting feature, whereas scleritis, I said, more often than not they have a systemic association with an autoimmune disorder, and rheumatoid arthritis is the most common cause of scleritis. Okay. Vaginous granulomatosis forms a very important systemic association because it can be life-threatening if not treated adequately. Then the others are polyarthritis nodosa, SLE, Behçet syndrome and metabolic disorders. So true about episcleritis is idiopathic many a time. Yes, that's true. Is associated with severe pain? No, not really. It can have just foreign body sensation. Stains with fluorescein? No. Whenever there is a limbal nodule that stains with fluorescein, that means you are probably dealing with a conjunctival ulcer. Always associated with uveitis? Not at all. So the right answer here would be A. So what are the two types of episcleritis we discussed? Nodular and diffuse. So let's take a question at this moment here. A 45-year-old lady presents with pain and redness in both eyes for around 2 months, which is gradually progressive. Okay, so there is pain and redness. She also gives a history of morning stiffness of joints. So there is some amount of autoimmune component here. Ophthalmic examination shows the following picture. So what do we see here? We see a nodular scleritis. Okay, so if you have a doubt whether this is episcleritis or scleritis, don't panic, because look at the question. They say there is pain. Okay, episcleritis will never bring, it will never present to you with pain. So most commonly, like, you would like to see this patient on a slit lamp. So presence of a scleral edema and engorged deep vessels will tell you that it is scleritis. But when you are in a doubt, just go back and look at the question. So we have a nodular scleritis. Probably it is a non-necrotizing. So the fundus is normal. So what is false about this condition? The common association is rheumatoid arthritis. Yes, we discussed this. Can be treated with oral indomethacin. Yes. Scraping is necessary for starting treatment. No. Scraping is done only when conventional therapy with steroids fail. So when steroids are not acting, then probably you have to think of infective etiology. So scraping is performed only in such cases. Should be treated on an urgent basis. Yes, it can have a systemic component which can be life-threatening. So this has to be taken on an urgent basis. So the right answer here is scraping. Okay, so let's go to the next question. The following are true about scleromalacia perforans. Okay, what is this? This is a new word here. Scleromalacia perforans. What does this word mean to you? Malacia means thinning or melting. Perforans means perforation. So the sclera is melting and perforating. So this is known as white eye scleritis. In the sense, there is minimal inflammation. So this belongs to the category of necrotizing scleritis without inflammation, the last category that we saw in Watson and high risk classification. So where do you get these? These you get in elderly women, and usually they have rheumatoid arthritis on a long term, and they do not have any pain or any symptoms. They just develop scleral thinning, and the dead sclera becomes like a sequestrum, like a bone. It becomes dead and white and gets separated from the rest of the sclera, eventually leading to perforation. So this entity is known as scleromalacia perforans. So let's look at the options. It happens due to inflammation of the small vessels leading to obliteration. Yes. So this typically happens in autoimmune conditions leading to obliteration of the small vessels, causing kind of a necrosis or ischemia. Okay. It is seen in association with polyangiitis obliterans. No, it is usually associated with rheumatoid arthritis. Pain is conspicuously absent. Yes. It can be bilateral. Yes. So the right answer here is B. Hope it's clear. The next question, this is a long clinical question here. A 55-year-old male presents with acute pain in the right eye. Okay, so there is pain in the right eye 8 weeks after going a retinal detachment surgery. So there has been an intraocular surgery and it's not been very long. So 8 weeks associated with pain. Vision is a little less, it's 18 and 8. Other eye is fairly okay. Okay, on slit lamp examination, the sclera at the site of incision was appearing thinned out and surrounded by congested deep scleral vessels. So what does this mean to you? There is some amount of scleral inflammation along with thinning. So this probably we are dealing with some kind of necrotizing scleritis. So systemic investigations revealed a positive RA. So what does this diagnosis point to you? Pain associated with a surgery done some 8 weeks back. So there is an entity known as SIMS, surgery induced necrotizing scleritis, okay, or post-operative necrotizing scleritis. This is usually seen after multiple surgeries on the sclera. It might be following a cataract surgery followed by a detachment surgery or something like that. Okay, so the time zone can happen between 8 days to 9 months. So that bigger range of time frame cysts can present. So which of these points in this case does not favor a diagnosis of postoperative necrotizing scleritis? Postoperative period of 8 weeks, no. The time frame looks adequate. Presence of pain, no. Pain is reported to be present in cysts. Presence of congested vessels at the scleral thinning, no. This is also an important feature. Positive RA factor, yes. So just because RA factor is positive does not make it scleromalacia perforans. Presence of RA factor does not make it an autoimmune condition. So this is surgery inflicted necrotizing scleritis. So the presence or absence of an RA factor is not required for the diagnosis of cysts. So the answer here is D. Posterior scleritis presents as a diagnostic dilemma. All of the following are reasons for the same, except signs are non-specific. Yes, the signs may be very non-specific. See, in scleritis, anterior scleritis, you get a nodule or you get a scleral redness, you get congestion, you get scleral edema. All these are conspicuously absent in posterior scleritis because you are not able to visualize the posterior sclera. The symptoms do not correlate with the severity of inflammation, right? The symptoms may be much more. Many a time there is severe pain, there is proptosis, and you may not see much inflammation on examination. It may not be associated with anterior scleritis on all cases. Yes, posterior scleritis can occur in isolation. B scan findings are non-specific. No, this is false. Okay, B scan is very, very specific for posterior scleritis. We get something known as a T sign. I'll show you in the next slide. This is due to presence of fluid in the subtenon space. So posterior scleritis is a diagnostic dilemma due to all these reasons that I told you, but B scan helps you to pick up the diagnosis. So this is how a B scan of a posterior scleritis looks. So here is the stem of the T and this is the base. So this is due to the edema around the subtenon space, and this is the optic nerve head shadow. Okay, so what is posterior scleritis? The etiology is similar as anterior scleritis. TB and other autoimmune conditions have more preponderance. It can be bilateral. Okay, so it may or may not be associated with anterior scleritis at all, and then it presents as an isolated posterior scleritis. It is a little difficult to diagnose. The symptoms are severe pain and ocular discomfort, and the visual acuity varies depending on where the which part of the sclera is affected. If the sclera just behind the macula, just beneath the macula is affected, then there will be some amount of macular edema causing visual loss. But if the scleral inflammation is somewhere in the periphery, you may not have visual complaints at all. So what are the posterior segment findings? You can have macular edema, you can have choroidal folds, you can have optic disc edema, and you can have an exudative retinal detachment. So these are all non-specific posterior segment findings which will never tell you this is a case of posterior scleritis. So what are the investigations that will help you? One is FFA and second is B scan. So these two help you to clinch the diagnosis of posterior scleritis. Sometimes you may also have painful ophthalmoplegia and proptosis. Okay. So the T sign I have already explained it to you. So how do we treat episcleritis and scleritis? Nodular episcleritis doesn't usually need any treatment, but you can give some NSAID to console the patient. Mild steroids like loteprednol or fluorometholone can be given. Oral NSAIDs can be used when it doesn't respond to even these three medications. If it is an anterior non-necrotizing scleritis, you can do away with topical steroids and cycloplegics, and what is must is systemic prednisolone along with immunosuppressants depending on what autoimmune disease you are dealing with. Anterior necrotizing scleritis, you have to be a little more aggressive with systemic steroids and immunosuppressants, lubricants, and along with that you might need a scleral patch graft if there is a perforation. In posterior scleritis, the treatment again depends on what condition is causing. If it's a tuberculosis, you might need a anti-tubercular therapy also along with systemic steroids, NSAIDs and immunosuppressants. If there is associated macular edema and disc edema, you might need pulsed intravenous methylprednisolone. So coming to infectious scleritis forms a very small percentage of scleritis. So why do we need to know? Whenever these steroids are not acting and immunosuppressants are not acting, then you're probably dealing with infection, and this infection might get worse with steroids. So it may be associated with pus and abscess formation, in which case it's very easy for us to pick up if it is a infectious scleritis. Okay. Usually there might be multiple nodules which goes in favor of an infectious condition. Okay, there might be overlying conjunctival and scleral ulcers, as the granulomatous reaction is leading to the formation of these abscesses. Common organisms are syphilis, that is Treponema pallidum, Mycobacterium and fungi. So these are very difficult to treat. As I told, sclera is an avascular structure. So management may be you might have to do a scraping of the nodule, and treatment depends on the microbiological profile. So what is a staphyloma? Staphylus means in Latin, it means a bunch of grapes. So why grapes here? So what happens in staphyloma is there is ectasia or weakening of the outer coats of the eyeball, along with uveal incarceration. So definition of a staphyloma is ectasia of the outer coats of the eyeball with uveal incarceration. So if there is only ectasia, we just call it as ectasia, keratectasia. Okay. So what are the types of staphyloma? Anterior staphyloma occurs when more than 2/3 of the cornea is compromised due to perforation or an ulcer. Okay. Intercalary staphyloma is at the limbal area. It follows healing of a peripheral corneal wound or an ulcer at the root of iris. So the uveal tissue that is prolapsing out here is root of iris. What is a ciliary staphyloma? It is present 2 to 3 mm behind the limbus. So intercalary is at the limbus, ciliary is 2 to 3 mm behind the limbus, where the ciliary body is present, and it's usually seen in malignant glaucoma. Equatorial staphyloma is seen at the equatorial region, where the vortex veins occur, and it's usually following scleritis. Posterior staphyloma is not following scleritis. It is seen in pathological myopia. A 44-year-old patient comes to your eye clinic for a certificate for blindness in his right eye. On examination, you find that the following picture. Okay, what do you see here? You see a ciliary staphyloma. So what did we discuss? Ciliary staphyloma is usually associated with the malignant glaucoma. So let's complete the question first. All of the following are probable causes except episcleritis, scleritis. Okay, scleritis can cause staphylomas. Malignant glaucoma, yes. Perforating injury, yes. So the right answer here is episcleritis, because episcleritis can never cause a staphyloma. So trauma to sclera. Scleral tears can be a part of perforating injuries or blunt trauma. Scleral tear require massive force, so they usually associated with other ocular pathologies like subluxation of the lens, posterior segment hemorrhage, dialysis of the retina. So the prognosis is usually poor and depends on the extent of the injury. There may be associated prolapse of the choroid. In blunt trauma, the globe rupture is in the region of Schlemm's canal, just that we had discussed. And the principles of treatment include ruling out foreign bodies, repositing the uveal tissue, and suturing the sclera with 9O or 10O monofilament sutures. So here we are closing the sclera chapter. So we'll see you next week with a new chapter. See you all later.